Kathleen, you want to jump in here?
Well, I don't know where to jump exactly. First of all, the law, unlike the drug plan that was passed in the prior administration, is fully paid for. There may be disagreements about how it's paid for, but the Congressional Budget Office continues to say that having the Affordable Care Act in place not only is paid for, but actually reduces the deficit. If the promises of repeal were to go forward, the deficit would go up. That has been demonstrated over and over again. I would say that the $2,500 premium issue that continues to be debated is a look at what health care would cost that average family if they were paying on the old trajectory. There is no question at all, again, hopefully we can agree that this is a fact, health care costs have risen at the lowest rate in this country in 50 years. Medicare costs, Medicaid costs, private insurance costs, overall healthcare costs are rising for the first time at the rate of inflation, not double inflation, where we were prior to the ACA, and it has been year in and year out. No one has ever seen a trajectory like this, and it continues to this day. So there are currently about 22 million Americans, some in expanded Medicaid states and some in the marketplace, who have coverage today that did not have coverage prior to 2010. So the drop in uninsured is documented. It's been the biggest drop in the uninsured population ever in this country, the lowest health care inflation costs ever in this country, and people have coverage. But in states that have not chosen expansion, including Kansas and Missouri, there is a huge gap for the low-income individuals because that continuum of care isn't there. And I would just like to go back to the notion of stealing Medicare money to put it over here. The idea was that Congress and the federal government provided a stream of funding to hospitals to compensate for the number of uninsured people coming in and out of doors. And the more uninsured folks you had coming through the hospital door, the more money you got from Congress. The law was written to say, okay, as more people come through your doors who are insured, that payment for uninsured goes down. It was written before the Supreme Court case. It was written in a way that said we shouldn't double pay for this money. There should still be compensation for the uninsured, but it anticipated that all states would actually accept Medicaid coverage. So until Congress changes the law, the Missouri Hospital Association, the Kansas Hospital Association is looking at member hospitals who will be in more and more serious financial trouble.
Did you want to respond to it?
I did. I just want to, I think it's interesting you throw out the 22 million figure, which I'm not sure where you get that, but the Census Bureau just last month said that the actual rate in the uninsured wasn't the 18 million that was projected when the law was passed. It was 8.5 million, and that it's missed every mark. And I think that what's fascinating about this, and I think it's important for people to really think about this. What the law says is that the federal government is going to give more money to states to expand coverage for adults of working age who have no kids, no disabilities, and if they were working 33 hours a week at a minimum wage job, they would earn too much to qualify. The federal government's going to give more money to those individuals than to folks with developmental disabilities who have been languishing on waiting lists for years, to low-income elderly, to low-income to low-income moms. I don't think that's a priority. I think if we want to help those individuals, we should not give them a Medicaid card. We should help them get a job.
Okay. Yeah, go ahead. We're going to get a question.
I think this is an important point because this bears on the question of whether you want government making your healthcare decisions at all. The Wall Street Journal reported that the health policy advisors in the White House knew that if you like your health plan, you can keep it was not true. They told the political people at the White House that, and the political people at the White House said, never mind, he has to say it or else it won't pass. On deficits, what has unequivocally reduced federal deficits is states refusing to implement the Medicaid expansion. because that is federal spending and federal borrowing that will never happen. Whereas if Kansas and Missouri decide to expand Medicaid, then state officials will be increasing federal deficits with that decision.
Okay,
Can I interrupt on that?
Sure, go ahead.
I'm confused about that. As I mentioned, when the ACA was passed, it had to abide by a couple of things politically. It had to cost less than $1 trillion with the T dollars, and it could not increase the deficit. So then when they passed it, it actually met those situations. So as Secretary Sebelius mentioned, that's why when the U.S. House of Representatives has voted 50 times to repeal the law, it always increases the deficit. If that's true, then I'm not sure how we can say that any action within the ACA is actually causing us to borrow more from China, as is very common in the General Assembly.
isn't.
We're going to borrow more from China.
Yeah.
Well, the ACA levied a lot of new taxes, and it did things that create savings by paying my members less. But we may not like that, but I think it makes me question how we can say you need to borrow more from China when the law itself was more than self-sufficient financially. In fact, it brought in revenue that the government, it's a net benefit to them.
Okay, there are two things. I want to get a question, and the fact checkers, if you can come up with the latest facts you can on the number of people who have, the more people have insurance since the ACA. We seem to have a discrepancy here in some numbers. Maybe you can get us some good numbers. But Nick, why don't you give us a question? You have a question?
Yeah, well, we have a lot of questions coming in, Alan. This is not the Nick Haynes show. These are questions that we're getting right here, and we're like Radio Shack tonight. They've got questions, we've got answers. We're going to start with Dan Cass, who is with us. Dan, thank you very much. Your question for our think tank of experts tonight.
Thank you. Other than eliminating Medicaid or simply cutting what Medicaid pays healthcare providers, what are policymakers looking at to reduce Medicaid spending? And there's a second part to this. Is there technology coming forward? And by the way, I have some answers for that.
Okay. Who wants to?
Well, I think the best way to contain Medicaid spending is not to expand the program. And then the dominant idea among Republicans and free market advocates, which is the groups don't necessarily overlap, is that Congress, instead of giving states a matching grant where the more money a state spends on Medicaid, the more money they get from the federal government, they should give states a fixed amount and let them decide how to spend, how to use that money best to provide health care for the truly needy. Because when we're helping the poor, we're facing what economists call the Samaritan's dilemma. You want to help the poor. You don't want to let people go without medical care. Nobody wants to live in that kind of a society. But if you make such a generous guarantee of access to care to everybody, then a lot of people won't take steps to provide for themselves. They won't get out and get jobs so that they can pay for their own health insurance. And that happens in Medicaid a lot. There are a lot of people enrolled in the Medicaid program who don't need to be there. And we can talk about how that is. People who could obtain health insurance on their own. But states would be able to strike that balance between helping too little and helping too much in different ways, and we'd learn from each other's successes and failures. But what we have right now is a one-size-fits-all attempt to try to help the poor that ends up spending a lot of money for unknown benefit and encourages a lot of people to become dependent on taxpayers who don't need to be.
Well, I would agree with Alan that states should take the lead, and the good news is they have. With the expansion of Medicaid in 2010, states began looking at very innovative approaches to really look at delivery system reform, ways to promote primary and preventive care, ways to engage people in more sustainable health benefits. States were given opportunities to design their own programs, and what's pretty exciting about it is it has, I think 20 years ago, Medicaid could have been accused of a one-size-fits-all with very mandatory benefits and programs. It now has lots of variations across the country that are being tested and looked at as the best way to deliver care. Iowa has a Healthy Iowans program that is very much fundamental to that case. There are programs where the parents of kids are very much involved in the kids' benefits. So through the waiver system, through a lot of states really using the private healthcare market to mirror what's going on in private insurance plans. Many states have now designed Medicaid programs to look exactly like the benefit package that someone would qualify for in the private market, to make it much more seamless for families to move in and out. And while I think Alan is right, I think it's aspirational that if you ask people in this country, should everybody have health care, should we be helpful to people with lower income, the universal answer would probably be yes. But the problem is that we weren't doing that in this country. There were millions of people, and there still are millions of people who don't have health coverage, who may be able to provide for their families if they had mental health and substance abuse care and treatment, if they had an ability to be gainfully employed, if they, as parents, could have an opportunity to be involved. And so I think there's been a huge gap between that aspiration and what was actually happening.
Tarren, do you want to jump in here?
Yes, I just think the facts speak very differently to that. The whole approach of this law and this administration when it comes to the states is our way or no way. You look at states wanted to have a work requirement to actually pull people out of poverty rather than give them a Medicaid card while they are trapped in poverty. Denied. You have the case of nuns who asked for a health benefit that wasn't offensive to their religious beliefs. Completely denied. You have the case of state after state. Iowa, a great example. Iowa asked to reduce ER usage if we could go from a $5 copay to an $8 copay. Denied.
Iowa has expanded their Medicaid program. We approved the governor's plan.
You did.
We
you
did.
repeatedly
We did.
denied
Iowa
key
had-
aspects of the governor's plan.
We negotiated
Well,
with
okay.
Iowa, but Iowa is correct. Iowa has expanded Medicaid. Republican governor expanded Medicaid in Iowa.
Correct, and this is how negotiation happens with the federal government. We like your ideas, we're going to reject them all, and we're going to publicly say we've accepted your plan, and then let you decide if you want the political
Well,
blowback to
that's
say it's
not
very
accurate.
different than it was presented.
Okay,
It's just
so
not
let me jump in
accurate,
here for just a second,
unfortunately.
because what we're trying to do, I saw some hands getting close to the bells over there, so we want to bring this thing down. I think this. I think. Well, first of all, I mean, and correct me if I'm wrong here. I believe several states have received waivers for their Medicaid
Including
plans.
Iowa.
I think initially the hope was there's no waivers were going to be part of the program, but obviously that changed with the response from the states. All I'm trying to say here, though, is and the other question that I would sort of direct to you is you made a comment that somehow expanding the Medicaid would keep people from working or pursuing jobs. The only thing I can tell you is that in Missouri, according to the information I have, there are 147,000 people who fall into the gap, okay? In other words, they don't qualify for Medicaid, they don't qualify for subsidy, and 67% of them are working families. So probably if they had access to Medicaid, they wouldn't stop working, or is your premise that they might?
Well, if I can defend Kathleen actually for a moment, a lot of the waiver ideas that were brought to HHS are things that are just not permitted by federal law. So the administration could not approve them. And that actually makes the point that, yes, it is one size fits all. There's a little bit of flexibility, but states don't have the sort of flexibility that they should have to spend this money that Washington took from their state and then threw back at them. Now I've totally forgotten your question, Al.
That's okay, don't worry about it. We'll get back to it in a minute. He wanted to ask something, then we're going to get
I
to that
wanted
question from the
to
audience.
focus on the aspect of the question relating to cost. Let me point out two things. Well, first, I think we all agree entirely that it is a good thing that states be the laboratories of democracy. Again, I worked for the state legislature for a long time. It's important to have 50 state legislatures out there doing different things and looking for waivers for different ways, because not everybody is going to approach this the same way. But on cost, I'd mention two things. It troubles me a bit when people talk about Medicaid cost, because Medicaid is a pretty varied program. In Missouri, 28% of the enrollees are aged, blind, or disabled. They generate 64% of the cost. That's not what's the issue here. If you're over 65, nothing we say tonight affects you. because Medicaid is a nursing home program. You probably know your mothers, your grandmothers are in nursing homes. They may not be Medicaid, but a lot of their fellow residents are. The second thing I'd mention about cost, and I agree completely, there are certainly ways to improve it. I think Mr. Bragdon has a lot of good ideas from what I've seen from the website. But let me quote you some statistics about Missouri. Again, can't talk about Kansas, but in Missouri, of the Medicaid hospital costs that were generated, I believe, in 2012, 5% of the enrollees generated 52.3% of the cost. You might say, that's terrible. They're abusing the system. Well, our data people looked at it and said, well, let's look at people who aren't on Medicaid. 5% of the enrollees generated 50.3% of the cost, essentially the same. We've tried to emphasize that if you want to do something about cost, you find those people and you manage them. So I'd like to make that point.